Good afternoon, everybody. This is Bill Ellsworth, Equitable Life and Casualty. I want to take just a minute here to welcome everybody to the webinar. I want to thank you for joining us. I've got a lot of exciting stuff here to talk about, so I want to jump right in and get started. Before I do, I have Gershon Georges on the other end of the webinar with us. As we move through this, if you have any type of questions you want to type in, go ahead and type those in. She will try to get a lot of your questions answered as we go through here. And then we will read those questions back at the end of the webinar to try to get everybody's questions answered. So again, if you have any questions, get them typed in as we move through. And again, thank you for joining us. So let's go ahead and jump right in. We want to talk about the EquiCash hospital program and how that fits in today's marketplace. I want to show you where all this product is available at. As you can see, we've got a very, very good representation throughout the United States on this product. If you are listening from Florida, this product is also available on our sister company, Heartland National Life. And in Florida, we've been writing that product in Florida for a couple of years. It is the leading state for this product. They are writing a ton of this product down there. It's working out very good for their agents. Agents are making a very good income from selling this, as you will see as we move along through here. So if you're listening from Florida and want to contract in Florida, go ahead and contact us after the webinar. We can get you selling there also. Talking about a little bit about why this product was developed, as far as what caused this product line to hit the market and become so popular. Well, the main thing that caused a product like this to become popular would be a product called Medicare Advantage. And as you well know, right now there's a lot of agents that are finishing up their certification for the 2014 enrollment season. And the hospital indemnity programs are going to figure in for a lot of good agents. It's going to figure in to put a lot of extra dollars in their pocket. I just had a large producer call up here, and we were talking about this product. I'm going to do a private webinar for his agency. He made the comment he thinks his agents are doing the prospect a disservice by putting them on a Medicare Advantage plan and not enrolling them in a hospital plan, and I have to agree with him. So why was the product developed? When Medicare Advantage hit the market back in 2005 to become effective January the 1st, 2006, nobody really knew how these products were going to work, including yours truly. It was a pretty good time in my life. I had this huge block of Medicare supplement business. I lived in Saline County in Marshall, Missouri. And every company that was in the Medicare Advantage market landed in Saline County with a zero premium hospital plan. So I'm thinking, okay, I started building my Medicare supplement renewal block of business back in 1984, and all of a sudden, 20 years later, here comes a product that's going to cause me to lose all of my renewals. Well, not only did that not happen, it caused my Medicare supplement renewals to grow, but it also gave me a huge opportunity in the Medicare Advantage or Part C of the Medicare arena. So that was a lot of reason why this product was developed, to go hand in hand with the Medicare Advantage marketplace. Now, there's also other places that we see agents adding this program on. I have a couple of agencies that add it to high deductible Plan F Medicare supplements. They get the premium down to hardly nothing with a high deductible Plan F, and then they add this on to offset some of the out-of-pocket expense. We have some people adding it on to people who are in my age group. I'm 61 years old. Right now I'm paying about $900 a month for insurance for myself and my wife. So I've already changed my deductible from a $1,500 or from $1,000 up to a $2,000, $2,500 deductible, and probably considering raising it to $5,000. But by doing that, I open myself up to exposure should I go into the hospital, quite a bit of exposure. If my wife and I would both end up there the same year, that'd be $10,000 right off the back. So if I do that, I will add this to that situation to where I can offset my major medical exposure. By adding this, I can do that very cheap at my age. So we see people adding it there. But again, primarily the product is made and designed for a side-by-side add-on with Medicare Advantage. So what I encourage everybody to do when they listen to this webinar is pick up the telephone when you get a few minutes. And if you're living in a metropolitan area, or if you have a lot of your clients that doctor in a metropolitan area, call one of the primary hospitals in that area ask to speak to the Medicare billing department, whoever files the Medicare claims. When you get that person on the phone, tell them, this is Bill Ellsworth. I market a lot of insurance in this area, and I'm just curious as to what plans you're accepting this year. You need to know that anyway if you're going to write Medicare Advantage. So you will get answers like, well, are you referring to the Medicare replacement product? So stop and think what that person just said to you. Are you referring to a Medicare replacement? We are not taking people out of the Medicare program, but we are replacing Medicare A and Medicare B with Medicare C. Okay? Why do people buy a Medicare supplement policy if they're on original Medicare A and B? They buy that because the Medicare supplement has deductibles, co-payments, and co-insurances. So doesn't it make sense to you and I as salespeople that are out there seeing people that if I'm taking them out of that situation and enrolling them into Part C of Medicare that also administers Medicare benefits, that maybe that Part C also has deductibles, co-payments, and co-insurances. So that's why this plan was developed, and a lot of plans just like it have been developed, is to fill in those gaps in co-payments on a Medicare Advantage plan. One of the top things that we get asked is this affordable with the economy being the way it is? Let me give you a couple of different examples as to why, yes, definitely it's affordable. You take somebody that's turning 65, such as, in my age group. Well, right now I'm already paying $400 a month for my major medical. By the time I'm 65, it'll probably be $600 or $700. Do you think I can afford a zero premium Medicare Advantage plan and maybe a $60 or $70 a month add-on? Well, that seems like gold to me. So there's definitely a situation. It is affordable. If you're somebody that's turning 65, they're used to paying quite a bit of premium. You can either walk away from it and just write the Medicare Advantage and leave that money on the table, or you can offer other solutions to those situations. Take somebody that sits down with you or me and they say, you know what, Bill, we're living on a fixed income. We're paying $200 a piece, almost $200 a piece for our Medicare supplement. That's almost half of our Social Security benefit. We just can't keep doing that. We're going to have to make some changes. Well, if you're in the senior market and somebody says something to you, they're asking you for a solution. So at that point, you can write them in a low-cost Medicare Advantage plan or maybe a zero-premium Medicare Advantage plan. And if they're used to paying close to $200 a month, they will think what you're showing them, if done properly, is a tremendously good benefit, and it is, for about $65 to $70 a month. Saves them money, it still gives them a good benefit package, and you're rounding it out by offsetting some of the higher co-payments and deductibles in their plan. So definitely don't worry about this being an affordable product. It is definitely an affordable product. And what I always tell guys, I say, well, you can either sell it to your client or you better hope I don't go in there and see him, because I will. So somebody's going to sell it to them or approach them with that unless you and I do it to our own clientele. So one of the things that we want to cover here also in this webinar is what's in it for you, the agent. Why would you want to do this? Well, number one, your needs should always be a benefit for your client. That should always be your forefront. And then what I did is I just took a basic plan, stripped it down to a basic 65-year-old, and by the way, this would be for a male or a female, and a 65-year-old with $200 a day per hospital benefit, and I added a $10,000 lump sum cancer rider, and I will cover the need for that and why I market the cancer rider almost every time I sell this. So what I came up with when I done that was an average monthly premium of around $62.80, and if you take that times 12, you're in about the $800 range, and an annual commission on that's going to be, an average street comp's going to be around $452. So guys, if you can sell two of these, a husband and wife, just 2 sales per week, you can increase your commission by $45,000 a year. Now, I'm not asking you to change everything you're doing. I'm just saying you need to consider adding this to what you're doing. You know, if you're selling Medicare Advantage, you need to be marketing these products. People are buying them, and I'll give you some reasons as to, I just went to a Medicare supplement convention this week in Phoenix, I left on Sunday, got back last night, and some of the things that they were talking about as far as the observation units in hospitals, I'll cover that shortly, but I guarantee you this is going to be a product you'll want to sell versus what the competition is doing based on what we found out this week. So that's what's in it for you, the agent. And then I think one of the most important things, guys, gals, is when you listen to a webinar, hopefully the person giving that webinar has a little bit of experience of how to market and how to present this product or how to sell the product. I started selling Medicare supplement insurance back in 1984. I still get out in the sales field, not near like you guys do, but you know, if I can get out once or twice every 2 or 3 weeks, I think I'm keeping up. But I can't hardly get out of this office that much anymore, but I like to keep doing that because I like to keep fresh on what our field force is running into on a week-by-week basis. That way it keeps me sharp. It lets me know what you guys are running into, what the competition's doing, so that I can help you if you do call in. So how you present the EquiCash product, we are going to talk about that here shortly. At probably the last 10-15 minutes of the webinar, I will give you a very, very effective presentation. So before we get to that, let's go ahead and go through the product. We have 3 different benefit levels in most states: silver, gold, and platinum. If you're listening from Florida, again, we couldn't file the silver benefit. We had to offer the gold or the platinum. And again, that's on our sister company, Heartland National Life's paper. So if you want to get contracted in Florida, let us know. We can handle that. So let's talk primarily for today's webinar about the silver benefit level. The silver benefit level is a 10-day maximum benefit period, and that is for each period of care. You can write that anywhere from $100 per day in $50 increments. So you can go 100, 150, 250, all the way up to 500. Now, if I were to just turn this brochure over, and I will later on in the webinar, you will see all the rates are neatly stacked out there. It's a very simple product to price, a very simple product to sell. But for right now, let's talk about the daily hospital benefit, and we'll get to that. The 10-day maximum benefit period for each period of care. So what defines a period of care? A period of care is separated when your insured gets discharged from the hospital. They have to be out of that hospital for a maximum or a minimum of 30 days. So as an example, let's say you got out of the hospital, you were in the hospital December the 15th through December the 31st. So you'd been in the hospital 16 days. Well, that exceeds that 10-day maximum, so we would stop paying after the 10th day. Okay? So they got out December the 31st, and they were out of the hospital the entire month of January and went back in on the 1st of February. That would start them out with another 10-day benefit period. Most of the competition has a 60-day separation. We are only at 30, so that's a very, very big benefit to you in the sales field when you're marketing this product if you're competing against the competition. That's one of the things you want to look in their policy. Get your policy out. Let's look at it. Period of care is defined by 60-day separation. We're at 30, so that's a good deal for you guys out in the field and me. The durable medical equipment benefit. We're at $200 per occurrence per calendar year. Guys, this is an indemnity product. Let's say your insured comes out of the hospital and they've got a piece of durable medical equipment and the co-insurance on their MA plan's $100. File a claim with us, we're going to send them a check for $200. If they end up in an ambulance, the benefit's $100 per occurrence. As you well know, most ambulance benefits are $150. But drop right down to the emergency room. Most emergency room co-payments are $65. So we're paying $150. So if they end up in an ambulance and the emergency room, which if they end up in an ambulance, they're going to the emergency room, you're going to have about $215 worth of co-payments and $250 in reimbursement. Now, that brochure in front of you says $150 for the emergency room per emergency room visit following an accident or an injury or a sickness. We will also pay that benefit and have been paying that benefit for over 3 years for sickness. It doesn't just have to be an accident. We will pay for sickness. Most of the competition will not. And I'm going to come back and readdress some issues here in just a minute. The physician's benefits, $25 per visit with a $75 calendar year maximum. That's not a lifetime maximum like some of these others are. It's a calendar year, and that's for a follow-up visit after a hospital stay. Now, what I do when I'm in the sales field, I highlight for follow-up after a hospital stay because I want them to realize that's what it's for, not every time they go to the doctor for a routine visit. Or if I don't have my highlighter, I will draw a couple of heavy lines underneath that for a follow-up after a hospital stay. Now, make sure that they're aware of that. You don't want them to go and say, well, it's not paying my routine office calls, so make sure you explain that to them. If you've ever been in the hospital or had a loved one in the hospital, one of the last things the doctor says when he is making his follow-up visits for discharge is he'll say, now, Bill, this is Thursday. I'm going to get you out of the hospital here this afternoon. I'm going to want to see you back in my office on Monday or Tuesday. Go ahead and make an appointment when you get checked out of here because I want to make sure everything's going all right. That's what this benefit is created for. Then we also have your option for a lump sum cancer rider. You can write that anywhere from $1,000 to $10,000 in $1,000 increments for first diagnosis of cancer. Now, that is skin cancer. That is internal cancer. So you can write $1,000, $2,000, all the way up to $10,000 in $1,000 increments. Now, for the life of me, I see a lot of these plans come through without the lump sum cancer rider added to it. I don't understand that. With cancer being as rampant in this country as it is, every one of these plans sold, I think, should have that cancer rider put on it. And sometimes it's how we frame the argument as to whether or not the insured buys that argument or buys that rider. If we just say, well, for another $29 a month, I can give you a cancer plan. No, I don't need that. Then you're going to lose that argument. But if you frame your argument properly, I think you can understand with cancer being prevalent in men over age 65, the odds are 1 in 2 that they'll have cancer sometime in their lifetime. If you get that person talking about that, he's going to tell you people he knows that's had cancer. Maybe he's had cancer. Maybe some of his family members have had cancer. On women, it's 1 in 3. If you were to drive down the street and every other house you've seen was on fire, do you think the houses in between would make sure they had insurance against fire? Of course they would. Well, the same statistics apply toward cancer. 1 in 2, 50% chance for men to get cancer sometime in their lifetime once they hit 65 years old. So let me give you an example of what I done just recently. I had a man over in Kansas, Overland Park, Kansas, and by the way, his wife just turned 65 about 3 months ago. I wrote her the same thing I'm going to tell you about him. He was 64 years old. I have his mother-in-law insured, and that's why he called me. It was a referral. So when I get over there, I discover that his major medical is around $450 a month. He's got a $2,500 deductible, co-insurance, $80, $20 to $10,000, and a $30 office copay. So I put him in the Kansas City area. If you're familiar with that and you're listening from around here, you know that Coventry's Advance for Freedom PPO is a very, very good product. So I put him on that. It was 0 premium. And I wrote him the silver benefits that you're looking at right there. You got the $300 per day. I started $300 per day. I got the ER at $150, ambulance at $100, the durable medical equipment benefit. And when I was presenting off of this, he could see right there in front of me, it says optional lump sum cancer rider, and I priced it with a cancer benefit, which the total premium come up to $68.14. And he said, well, do I have to make up my mind on that cancer plan today? I said, no, you sure don't. But I said, before you make that decision, let's look at some information and some facts, and then you can make your decision. And he was okay with that. So I said, I'm going to give you my legal pad. And I said, I want you to write some numbers down on this legal pad. I'm a big legal pad user when I'm out in the sales field. So I told him I said I'd already looked at his age at $2.90 per thousand. You take that times 10, that's $29 a month. So I said, take 29 times 12, and I'll tell you what the number is. So I had him write 29 times 12 on the legal pad. And I said, that equals 348. So I said, now take 10,000, write that down, and then divide it by the 348. And I said, I'll give you the number. So I divided the number out, and it came up to about 28.75. So I showed it to him. I said, just round that off to 29. So he wrote 29 on his paper. And I said, do you know what these numbers represent? He said, well, I think so. But he said, go ahead and make sure we're on the same page. So I said, okay, the $348 is how much that rider costs you every year. You've got a $10,000 benefit. You would have to be 94 years old. You're 65 now. You would have to be 94 years old to have more paid into this than you would get out of it in benefits. So I said, Larry, let me just ask you one question. With a 1 in 2 chance of developing cancer sometime between now and the time you're 94, do you think there's any chance that you might come down with cancer? He said, well, based on those odds, yeah. I said, well, I think this is in your best interest, don't you? He said, I never thought about it that way. Go ahead and do it. So how we frame our argument when we're selling benefits, again, guys, I'm selling benefit, not price. He realized the value of the benefit. 29 years he would have to pay into that before he got less out of it than he was paying into it. I mean, it was a win-win situation for him. There's no way that he could look at that and say that's not a good benefit. And he could afford it. He was living in a $300,000 house, and he was paying $450 a month for his major medical, so there's no doubt he could afford it. He just didn't realize the value until I reduced it down to the ridiculous, is what we usually call. So he's seen the value, we added it, and by the way, it wasn't really hard to convince his wife to the same benefit when I went back to see her about 3 months ago. So I walked out of there with a first-year comp on a MA, and I walked out of there with over $400 commission on the add-on for the benefits. For an hour's work, I made a little over, not close to $900, not quite. So to me, that's a pretty good payday as an agent, and that made them a very, very good benefit. So take a look at that cancer plan, break it down to the ridiculous, and add it to it. Another situation that you can do to make the realization that this is a good benefit for people with Medicare Advantage plans, when they come down to the Tier 1, 2, 3, and 4 drugs, as you well know, specialty drugs are generally in the 33% range. Well, a lot of cancer treatment is done on an outpatient basis, and they take specialty drugs, considered specialty drugs. How long do you think it will take them to go through the donut hole if they're taking a drug that's costing $1,200, $1,300 a month? Not very long. So I always, if they don't go for the $10,000, I always present that argument, say, you at least put $5,000 on here to protect yourself. I said, you're going to end up with chemotherapy, radiation. You're going to pay a copayment every time you get that. Guys, gals, this is a great benefit for you, and it is a good benefit. I had a lady just recently, I had presented, you don't always win in this situation, but I presented the cancer benefit to her, and she just didn't want to turn loose of that extra $20, $30 a month. So I didn't put it on there. Guess what? She's treating for cancer right now, and she's really, really beating herself up because she didn't accept that rider. I'd have a policy right here on my desk, and it is for a lady that I was a referral from the first lady that I was just referring to. Her name's Miss Torbert, Jan Torbert, and she lives also here in the Kansas City metropolitan area. She's a good friend from the lady that had got cancer. She called me up and she said, can I increase my cancer benefit $5,000? I think I want to do the 10 like you originally suggested. So the word gets around. Really, really put some thought and process into this lump sum cancer rider, guys. It'll make you more money, and you're really doing a service to your client. So let's go back and talk about a couple of other benefits about what sets this plan apart from maybe the competition like Guarantee Trust or some of the other supplemental plans out there. First off, guys, gals, these are hospital indemnity programs, meaning you have to be hospitalized to get benefits. So let me give you an example and tell you what separates us from a lot of the other companies out there. Let's say you've wrote this policy and one of your clients is sitting around the house and they start having chest pains and they think they're having a heart attack, and their wife gets all excited or their husband gets pretty excited and they say, let's get you to the emergency room, get you checked out. You go to the emergency room, the doctor runs all of his tests, and he sits down and he says, you know what, Bill? He said, I've run all these tests. I don't see anything. The EKG is fine. I'm going to let you go ahead and go home. I wasn't hospitalized, was I? I went to the emergency room, I went home. And that was a sickness that I just described, not an accident. If you have the competition, such as Guarantee Trust, which is a good company, but you guys need to know the difference in how benefits are paid on these plans. So on the GTL situation, no benefits going to be paid. They were not hospitalized, and it was a sickness, not an injury. Okay, we will pay that claim. As Vice President of Heartland National and the Vice President of Sales of Equitable Life Casualty, I'm here to tell you we will pay that claim. And we have been paying those claims for over 2.5 years. Now, Let's take it one step farther. Let's say that you're a single individual and you have chest pains and you think you're having a heart attack, so you have to call the ambulance. And the same thing happens. The ambulance picks you up, the ambulance takes you to the emergency room, and the doctor runs all these tests, and he says, Bill, you're okay, I'm going to let you go home. I think it was an anxiety attack. They're going to get the same denial letter from the competition, and we're going to pay not only the ambulance benefit, we will pay the ER benefit. Sickness or accident, I don't care, we're going to pay it. But now here's the real kicker. When I went to this webinar, or this seminar out in Phoenix this past week, actually this week, one of the things that was discussed, one of the topics was supplemental benefits in the upcoming years with Obamacare. And hospital indemnity plans were talked about. Do you guys realize, and a lot of people don't, that you can be in the hospital under an observation stay for a maximum of 3 days and still not be declared an inpatient? If you sold a policy to somebody and they were in the hospital for 3 days and it got billed to Medicare as an observation stay, how do you think they're going to feel about that? In their mind, they're hospitalized. So let me give you this, let's take this scenario one step farther. The ambulance comes and gets your client, the ambulance takes that person to the emergency room, and the doctor says, you know what, Bill, I think you're okay, but I think I'm going to put you in the hospital tonight, see how you do. If you're okay, I might let you go home tomorrow afternoon. In that situation, what do you think your client in their mind thinks? I'm in the hospital. I just got put in the hospital. Only to get a letter from the insurance company to say, you know what, Bill, you weren't hospitalized. You were in an observation bed. No benefits are payable. So deny, deny, deny. You guys need to understand that we pay for observation beds. This is a huge, if you're competing against an existing plan out there, make them get the policy out. Point these things out to them and then show them where your policy's different. It's a slam dunk. You won't, if they can qualify health-wise, I assure you it's a slam dunk. You won't lose that sale. You will make it every time. So let's take my example and say you wrote a 500-day hospital plan and they were in the observation bed for 2 days. Would you rather them have a guaranteed trust policy that's not going to pay that claim, or a Heartland National plan that is going to pay that claim? So they'd get a check for 500 times 2, there's 1,000. They're going to get the 100 and the 150. They're going to get a check for $1,250. Do you think they're more apt to keep that plan or the one that denied their claim? If they have the one that denies their claim, you're going to get a call, and should expect it if that's what you're selling, from that client saying, you know what, Bill, that policy you sold me ain't worth the paper it's wrote on. I was out here in the hospital for 2 days and I got nothing. I'm canceling it. And by the way, I sent you to my brother and my sister. I'm going to call them and tell them what happened to me, and they'll probably cancel theirs too. We don't want you to get those kind of calls, guys. We want you to have a happy client. You and I are in this business to build residual income. And by having a plan that pays benefits, people keep it. Sell on benefits, don't sell on price, and you'll be really, really dollars ahead in this business. Okay. The gold plan, I'm going to buzz through the gold and the platinum pretty quick. Not a whole lot of differences in the benefits, or just a little higher under each plan. We do have a lot of people selling the gold just because of the better benefits. You got a 20-day benefit period. Durable medical equipment benefit is up to $300. The ambulance is $150. The emergency room is $200, and that is following accident, injury, or sickness. And you still have your $25 follow-up after a hospital stay for the doctor's office, and you still have your ability to add the lump sum cancer rider. We do see quite a bit of the gold coming through just because the benefits are up there a little higher, and you got an extra 20 days or an extra 10 days on the hospital. You don't have to worry about maybe somebody still being in the hospital and running out of benefit on that 10-day maximum. The platinum, don't see a whole lot of this one coming through, but every now and then somebody will add this to a high deductible, major medical or something like that. It's a 90-day window. The durable medical equipment is $400. The ambulance is $200. The emergency room is up $50 but to $250, and then you have your two benefits at the bottom as the same: the $25 per visit for the hospital and the optional lump sum cancer rider. And again, you can do that in $1,000 increments, so you can write any combination there that you please. Okay, that's the 3 different benefits: silver, gold, and platinum. Let's talk a little bit about the application and the underwriting. Application is very, very simple. The first part one is all the personal information, the name, date of birth, address, city, and a good phone number and their age. Part two is your benefit selection. Are you doing a silver, a gold, or a platinum? If you're in Florida, again, your choices are only gold and platinum. The application will be a little different. Will this policy replace an existing accident and health insurance plan? Yes or no. If you are replacing a competitor's product, make sure you fill out the replacement notice. Let us know how many dollars per day you're writing in the daily hospital amount, $100 all the way up to $550 increments. The first occurrence cancer rider, hopefully you're filling that out with a $1,000 all the way up to $10,000 offering. The application, simply put, guys, gals, this is a yes/no application. We need you to be underwriters in the field. We don't follow up personal history calls with this. We don't do an MIB check. It's yes and no. And for us to do all that would add another layer of expense to this product. We think we have this product priced to where we should never have a rate increase. I can't guarantee that, but that's our goal. So we really need you to do a good job underwriting. And the last thing that you want to try to do is slip something through thinking you're going to get by. You're not. We'll catch it. So when you read those health questions to your insured, make sure you get good information. Make sure they give you good yes/no answers. So question number one, in the past 2 years, have you seen a doctor? Have you been diagnosed, treated, or taken medication, or been advised to have treatment, surgery, or take medication for internal cancer, leukemia, melanoma, Hodgkin's disease, or lymphoma? Let's say that you're sitting there with somebody and they say, you know, I think it's been right at 2 years since I had my colon removed. Now, it was cancerous, but I didn't have to have any follow-up treatment. Didn't have to have no chemo or anything at all like that. They think they got it all with the surgery. Do you take their word for it and say, I think it's been 2 years? Or do you say, well, you know what, Ms. Jones, before I go any farther, I need to verify that because that's a determining factor of whether you can get this plan. So make them get it out. If they don't know, call a doctor's office. The last thing you want to do is give the wrong information on the app and have the policy sent back at claim time. That's not good for you. It's not good for us. So dig in and get the right answers. You come down to question number 2 and go to the letter B. Have you been hospitalized 2 or more times or been advised to have surgeries not yet completed? And they say, well, you know what, Bill, I think I have been hospitalized twice. I know I was in the hospital back in June with pneumonia. I was out there for 3 days with pneumonia, and then I believe it was in February I was out there to St. Luke's East, and I had my cataracts removed off my right eye. Well, what just happened? She says, yeah, I've been in the hospital 2 or more times, but cataract surgery is outpatient. The pneumonia, that's a legitimate hospitalization. Cataract, outpatient. So even though she thinks she's been hospitalized 2 or more times, by clarifying and asking, you can actually answer that question in that example, no. So you could proceed. So let's say they answer all the questions in number 3, you do a good job, and they're all no. And they're really interested in that cancer plan, but you also know that they had internal cancer about a little over 2 years ago. That simply means they can't put the cancer rider on it, because we're asking for the past 10 years, have you had internal cancer? So, they could qualify for the base plan, you just couldn't add the optional cancer rider in that situation. But you may run into a situation, and I have had this happen, to where they say, well, you know what? If I can make it to December, I'll be cancer-free for 10 years. I'll have been done, and like December the 12th was the day I had my last radiation treatment, and that'll be 10 years go by. But all the other questions on 1 through 3 were yes. They could apply right there for the base plan, and on December the 13th, once you verify that was the right date, you can come back, fill out a new app, just write upgrade on there, put the cancer rider on there that they wanted to get in the first place, and you can sell the cancer plan at that time. You've got to be cancer-free 10 years to get the cancer rider. Premium payment, real simple. If they are the payer, then if the payer and the applicant are the same, you don't need to fill out name, address, and city because that's on the first page. But if you've got a different payer that's not the applicant, then that would need to be filled out. You're going to come down to your initial premium paid, and right below that in green letters, that must include a $25 application fee. That's a one-time charge only. They never pay it again. So, example, the premium is $50 and the policy fee is $25. You pick up one check for $75, informing your client that, Ms. Jones, you won't have to pay that $25 the next time when we draft your bank account. You're going to do an annual, a semi-annual, a quarterly on direct billing. If they want it monthly, it has to be on a monthly bank draft. I'm going to show you this right here. I never pick up 2 months. I always draw a line through that and just write 1 month out there like that, and check the monthly bank draft box and write 1 month. We'll issue it, get it out to you. We won't pin it and say, hey, by the way, Bill, go back and pick up that other month premium. I never pick up 2 months, always 1 month. I have seen times when I told people that, hey, you got to pay 2 months up front for a monthly bank draft. It kind of shoots you in the foot. A lot of people don't have a problem with it, but you don't want anybody to have a problem with it. So pick up 1 month, we're good to go. Come on down there to the renewal. Are you doing a direct bill? If you're doing a direct bill, it's got to be annual, quarterly, or semi-annual. And if you're doing a bank draft, is it a checking or savings? Fill out the bank routing numbers, the bank account numbers, and right across there it says select bank draft day. If you want us to draft on the 5th of the month, write it in there. And check I authorize bank draft payments. Now right above where it says select bank draft day, you see an open area there where there's no little boxes and there's nothing but a little white square. If you have special instructions, write them in there. Let's say that you're writing a policy today and the person's giving you a check for $75 and they're telling you, listen, I don't get my Social Security check until the 3rd week of the month, and they say, I don't want you to draft my account or cash this check until the 23rd of this month. Write that down right there in that little white area. Do not cash check until 9/23/13. If that's on the app and we screw up and cash it, then we will be liable for any problems that causes your customer. So if you don't put it on there, we'll cash it when we get it. So if you have issues or something like that, write it down, let us know what you want to do, and we will work with you. Okay, guys, that's the product, the 3 different benefit levels, silver, gold, platinum, how it works. What I want to talk to you about right now, and for the rest of this webinar, which we aren't far from being done, is how to sell the EquiCash plan. I think it's very important that you understand how to market this product. So hopefully this will be something that's very, very beneficial to you. What you see on you in a screen in front of you is what's called a scope of appointment form. If you are doing your certifications through CMS, through AHIP, or if you're doing certifications for all the companies, Coventry, Humana, United Healthcare, whoever it may be, you know what a scope of appointment form is. You have to keep this form on file for 10 years. There's always been a lot of discussion as to whether you can or cannot cross-sell hospital indemnity plans at the time of sale. Look at the form. It was approved by CMS on June the 12th, 2012, a little over 1 year ago. I have blown up 2 things there, the 2012 approval date and the hospital indemnity products to where you can see it better. I've been using a form just like this for about 3 years. It was approved on 11/10/10. So you can sell hospital indemnity products at the same time you sell Medicare Advantage if it is disclosed on the scope of appointment form. So when I send my scope of appointment form out, when I'm setting my appointments, I tell Mr. Jones, I have to mail you what's called a scope of appointment sale or form. You have to initial. There's 5 boxes there, and you have to sign it and date it and initial what you want to talk about. Now, if you want to talk about a Medicare supplement when I get there in addition to a Part C plan, I can't do it unless you initial that box. If you want to talk about a hospital indemnity plan, which most of my clients do, I can't do it unless you initial that box. So to be safe, Mr. Jones, most of my clients just put their initials in all 5 of those. That way we can talk about whatever we need to talk about while I'm there. I don't make the rules, but I do have to follow them. So I let them know they need to fill them all out. Send it back to me, and then we can talk about it. If you don't, we can't. So that form's been available going on 3.5 years, and I've been doing that, and I've never had a problem. If you work with a company that specifically requires you to use their scope of appointment form and that is not on there, I explain that to my client. I say, listen, some companies make me use their own form, so I'm going to send you two. Fill out both of them and send them back to me. If you have any questions on that, feel free to ask at the end, and we will go over that with you. If you need a copy of this form, I can email it to you, or Gershon can. If you want, it's probably better ever do it, not me. But we can get that out to you, and we can get you all these slides as far as that goes. If you want a copy of the presentation, we've got it on our website where you can go through and review it. So scope of appointment form, keep it for 10 years. You can cross-sell a hospital-related product. When you do your compliance, it simply says cross-selling of non-health-related items is prohibited, such as life insurance and annuities. Cannot do that under any circumstance. That's why it says non-health related. This is a health-related product. You're good to go if it's done properly. All right, from here forward, I'm going to show you how I do my presentation. If you have any questions on that, feel free to ask it when we get done here. We should be done in about 5-10 minutes. This presentation is very, very short, very, very effective. If you'll use it like I show you, you will close every 6 out of 10 that you talk to, and I think probably 7 or more should be your goal. Okay, so it doesn't matter if I'm selling a new product or if I'm reviewing an existing product in the home. It doesn't matter if it's United Healthcare. It doesn't matter if it's Coventry. It doesn't matter if it's Humana. When you come to number 3, it's going to talk about, and it'll say exactly, word for word, inpatient hospital care, includes substance abuse and rehab services. Your second column will be how original Medicare works. As you can see, I've been using this a while. It's got 2011 on it, but that's okay. That's part really not important. On the third column, it'll be Medicare, how the plan that you're selling addresses the Part A inpatient hospital portion of original Medicare. So under this plan, I'm using Coventry's Advantra PPO. Again, that's a really, really popular product here in the Kansas City marketplace. So when you come to the right-hand column, that's going to be, if I hit the right button, hang on, I got to get back to where I need to be. That's going to be for Medicare-covered hospital stays, days 1 through 7, $250 copayment per day. This is the Coventry Advantra plan. Now, remember me saying I'm a big legal pad user. I create on my legal pad on a fresh piece of paper a you pay column. Draw a line under the you pay. So when I come to certain benefits that I'm going to talk about later, they're going to see what I'm referring to. So when I come to the inpatient hospital care and I say, no, Mr. Jones, if you're in the hospital days 1 through 7, you're going to have to pay $250 copayment per day. I pause and I say this. Now, Mr. Jones, what that means is if you're in the hospital for 7 days, you are responsible for $1,750. Now, Mr. Jones, I don't want you to worry about that because I'm going to show you why that's not going to affect you and how you're not going to have to pay for it. Now, don't let me forget it, okay? So what have I done? I created a huge amount of money he's going to have to pay out of his pocket. I've told him not to worry about it, and it's his job to help me not forget it. I take that $1,750 and I write it in the first line under the you pay column. I move right along through the summary of benefits until I come to number 14. And 14 will be the same verbiage on in plan in the summary of benefits. Doesn't matter if it's Coventry, United Healthcare, they're all standardized. So when I come to number 14, I'll say, now, Mr. Jones, if you're in the ambulance, you're going to be required to pay a $150 copayment. That's air or ground. So it's going to cost you $150. Now, the ambulance is going to take you to the emergency room, and in the emergency room, you've got another $65 copayment that you're going to have to pay. And at that point, guess what I say? Mr. Jones, I really don't want you to get too worried about those 2 co-payments either. I'm going to show you why that's not going to affect you and how you're not going to end up paying it. Now, again, I get to talking about a lot of different things here, so don't let me forget it, okay? So now I've told him not to let me forget something twice. That's starting to resonate with him. And I've showed him some areas that's going to cost him some money out of his pocket. Okay, I proceed right along till I come to number 18, which is the durable medical equipment. By the way, I write the 65 and 150 right under the 1750 on my you pay column. And when I come to the durable medical equipment, I say, now, Mr. Jones, most Medicare Advantage plans are going to require you to pay 20% of what Medicare covers. Let me draw you an example here on my pad. So I move over to the right of that, and I write down total 1,000. And right to the right of that, I write approved 500. And I take 20% of that. I don't do it yet. I ask him a question. I say, now, Mr. Jones, which do you think Medicare would pay on what the doctor actually charged or what they told him he should have charged? And I kind of make a joke out of it. And I said, of course, they're going to pay 20% of the 500. So I take 20%, draw a line under that, under where I took 20% times 500, and I write 100. I said, guess what? You're going to end up paying that. And I write that over under the $65 emergency room copayment. Again, saying, again, Mr. Jones, really don't want you to worry about that because I'm going to show you why you're not going to end up paying those things. Then I move clear through the summary of benefits, and I go through the Tier 1, the Tier 2, the Tier 3, the Tier 4 drugs. And when I finish the Tier 3 and Tier 4 drugs, I simply fold that summary of benefits up, and I say, now, Mr. Jones, that's how your current program works. Do you have any questions? I've told him 2 or 3 times not to let me forget something. What do you think he's going to say? He's going to repeat back to me, well, yeah, Bill, he said there was a bunch of those charges you were going to show me that I wasn't going to end up paying. And I thanked him. And I said, I'm glad you told me, reminded me that I was getting ready to do something different. I'd already forgotten and was going to move on. So at that point, guys, here is your transition phrase. The hardest part for any salesperson, including myself, when you're cross-selling, is getting from product A to product B. And here is the perfect setup to do that. Go back one slide. I said, I'm glad you reminded me. He's already asked me about paying all those other those co-payments. I said, I'm glad you reminded me. And I'm going to repeat this paragraph to him. And it may not be word for word or verbatim as what you see on the screen, but I've said it enough times that it's word. But you need to be somewhere along this line. Medicare Advantage plans came out. We started pre-marketing them in 2005. They were all effective in 2006. So everything's 100% accurate on this screen. So you can simply say to him, if you weren't in the business in 2005 or 2006, you can change it to your situation. You can simply say, Mr. Jones, when we, and if you weren't doing it, it was when Medicare Advantage plans were first being marketed back in 2005, if you weren't in the business, I was, so I got this on there when we were first starting. So I simply say, Mr. Jones, when we first started selling Medicare Advantage plans back in 2005, with an effective date of January the 1st, 2006, no one, including me, sometimes instead of saying me, I'll say including yours truly, knew how benefits were going to be paid out. These were brand new plans. But what we noticed after a couple of years, our clients ended up paying a lot of money out of their pockets when certain scenarios took place. Mr. Jones, let me just ask you a couple of real quick questions. Have you ever been in an ambulance? Guys, gals, don't matter if he says yes, don't matter if he says no, your response is going to be virtually the same. If he says yes, you simply say, well, Mr. Jones, where did that ambulance take you? If he would have said no, you simply say, well, Mr. Jones, if you were in the ambulance, where would that ambulance take you? And he's going to say, to the hospital, invariably every time. But I'm going to say, I understand that, but what part of the hospital? And that's when they identify the emergency room. And I kind of make a joke. I say, yeah, that's right. They don't drop you off at McDonald's or Walmart to shop first. They take you straight to the emergency room. Usually it's a life-threatening situation, so they get you right into that emergency room. And Mr. Jones, that just triggered 2 co-payments on your Medicare Advantage plan, as it is for all of our clients. And I point toward the 65 and the 150. And then I simply say, now, Mr. Jones, one of 2 things will happen while you're in the emergency room. First off is they will stabilize you and send you home if they don't think you have a life-threatening illness. Or if they can't do that or determine what's wrong with you, what do you think they're going to do? He's going to say, they're probably going to put me in the hospital. And I agree with him. So that is exactly right. They're going to admit you to the hospital, and that's going to trigger the most expensive part of your Medicare Advantage plan. In this example, $250 for every day you're there. And Ms. Jones, that's why we created this program. I actually helped create it, so I say we. If you didn't, you can say, oh, Ms. Jones, that's why this program was created. At this point, remember when I told you, showing you the silver benefit plans, the daily benefit per day, and the cancer benefit riders? This is now the back side of that. All you simply do is you turn that brochure over, you go through the benefits, you see where that program fits their budget, and if they've been paying $200 or $300 a month for a Medicare supplement, or $400 and some a month for a major medical, trust me, they can afford $70 for this plan to make them a much more rounded plan for their Medicare Advantage plan. So here's where my example came from on my paper. The 64-year-old, if you come over to $200 a day, it's $30.70 a month. And I come over here and put $29 on it, that gets me to the $68 number. And that's what I ended up doing. So it's a very easy product to price out. All your modal factors are right down there at the bottom. And simple product. So guys, we can get this presentation to you, any part of it that you want. If you want to use it, I assure you it is effective. We have a lot of guys that get so busy during Medicare Advantage season that they sometimes don't write this plan, but they spend a whole lot of time the rest of the year going back and marketing it to their Medicare Advantage customer. So I always like to do it while I'm there, because if I don't get back until March or April to see some of them, that may be too late. They may have already been in the hospital and now not qualify. Always strike while the iron is hot is what I always say. Get it out there, get it in front of them. You'll sell a lot of it and make a lot of money. Okay, take a look at the state map again. Just about every state in the union covered, not quite all of them, but a very, very good presence there with this product. Again, if you're in Florida, let us know. We can get you hooked up in Florida also, and try to get you up and running there. My name again is Bill Ellsworth. I'm your presenter here today. You can reach me at bill.e@e-hfg.com. Kevin Williams is actually our national sales director. You can get a hold of him at kevin.williams@equilife.com. Ginger Abbott is another host and a very good lady for working with agents. Very, very knowledgeable. Been in the business about 20 years. You can get a hold of her at ginger.abbott@equilife.com, or you can reach us at 800-352-5121. And you can also get on our agency website once you are contracted and get just about everything that we've talked about here today. We've got a great website. So with that said, I'm going to be quiet for a minute and bring Rashawn, get your questions answered, and let you get back to your day. Rashawn?
Okay. Bill, one of the first questions I have is they would like to know if you do pay on the ER if they are not admitted.
Well, would you want me to say yes or no in that situation? The answer is yes. Okay. You do not have to be admitted. If they, guys, listen, the last thing I want, and as an agent, the last thing I want is for that client calling and jumping me. You know, they're paying premium. If they go to the emergency room, they're going to expect to be paid whether they get in the hospital or whether they do not. We do pay whether they're hospitalized or not. We also pay if it's a sickness and not an accident. Most of the competition is accident only. A huge difference. People go to the emergency room when they're sick. They don't just have to be injured. So we're going to take care of your client in those situations. So yes, good question. You can't hear that enough, but yes, we do pay even if they are not admitted to the hospital.
Okay. The next question they have is they would like to know if there is a 2-year contestable period.
As with any health insurance product and life insurance product, yes, there is a 2-year contestability period, and that's why you guys got to do your job underwriting. We have rescinded some policies on this, and if you were to say, you know, immediately everybody's thinking, oh, God, this is a problem. It's not a problem if you do your job. Don't tell me you can't see that they got an oxygen mask hanging out of their nose. That's a question. Don't say when you ask them the question, do you have a pacemaker or a defibrillator? And they say yes, and you check no. And they end up in the hospital a month later. We're going to check that out. And we're going to send that policy back. That's why I say, guys, do your job. Don't create problems for yourself. we do have a 2-year contestability. Every policy out there has a 2-year contestability.
Okay. The next question they have is, would they be able to drop the initial premium in the future? Is that something that we're looking at doing?
Nope, we can do it now.
Okay.
Let me make sure that I understand that question. Somebody's asking you or me, if I submit an app without any premium, will you accept that? Yes, we will. What you want to do in that little white box above the premium section I was describing earlier, just simply write on there draft initial amount, and then make sure that your client knows, because we may not do that for a while. It may be 3 or 4 days. If you mail the app in, it may be a week. And by the time your client sees that draft on their bank account, it's going to be $25 higher than what you told them the premium was. Just make sure that they're aware of that. So, Ms. Jones, now when you see this first draft, it's going to be a little higher than what I'm telling you the premium is, because it has that one-time policy fee included in it. So that way, we've had a couple of people call in complaining about that, and when we tell them, say, well, and then a lot of times say, oh yeah, he told me that, I just forgot about it. So just reiterate that with your client. Maybe write it on the brochure. Initial premium will be $75 higher than your bank draft. Or not 75, 25 higher.
Okay. The next question I have is, does the premium increase as client ages in the program? And the second part of the question is, can cancer be added a few years after issue or just be increased?
Okay, let me make sure I understand the question correctly. The first part of it, read that again and stop.
Okay. The first part they wanted to know was, hold on just a minute. Sorry.
Can a cancer rider be added or something?
Yes, that's what it was. They wanted to know if a cancer rider can be added after, we get this question a lot, after the policy has been issued, or can they up it? Can they increase?
Yes, you can, but now you've got to qualify them again. So if I understand that question right, say I just wrote the base policy and I didn't put the cancer rider on there. Yes, you can add it later. You can add it a week later. You can add it a month later. You can add it a year later. But if you add it a year later, you got to add it at their new rate, which ain't a whole lot of difference. So, but yes, you can add it as long as they haven't had internal cancer in the last 10 years. You can absolutely do that. But there was 2 parts to that question. What was the other part?
They wanted to know if they could increase it, if it could be increased.
Okay, it can. Like I said, I just did a lady that way last week, I believe it was. She had started out with $5,000. She had a friend of hers that got cancer that didn't have any, that wouldn't accept the cancer rider at all. And I always start at $10,000. It's easy to come down, so now it's easy to go up. Well, she didn't want to pay for 10, but she would pay for 5. Well, after her good friend got cancer and was paying all these payments out of her pocket because she's having chemotherapy, she called me back and wanted to know if she could up that to the $10,000 like we originally suggested. And I said, I'm on my way over to see you right now. So, yes, you can do that.
Okay. The next question I have is, what is the average turnaround time for a claim on a payment on a claim?
If it's a good, clean app, we pay claims pretty quick. If you write a policy today and 2 months later that person's in the hospital for 10 days, we're going to send off and get medical records, so that will delay that. But once you go by that 2 year, if it's been out there 2 years, we just, as soon as the claim comes in, it's processed. And we don't have to have a claim form, guys. That's a good question. Let me elaborate on that a little bit. We do not request make the doctor fill out a claim form or make the client fill out a claim form. We simply ask that get a itemized copy of the bill, send it to us, and we'll pay off of that, because on your itemized bill, it'll have how many days we're in a hospital. It'll have whether there was any durable medical equipment. It'll have whether there was an ER visit. So all of that will be there. So if they end up in an ambulance, have them call the ambulance, get the itemized bill, send it in with the policy number on it, we'll pay it.
Okay. The next question I have is, can this be sold over the phone?
Well, it can be. We don't have a phone enrollment like we do on our MedSup or our Life Plan. But what you can do is, if you have somebody that's interested in it, you call and talk to them, explain it to them, and they decide they want to buy it, you can simply email them the app or mail them the app, have them send it back to you with their signature on it, and send it in. but you can sell the benefits over the phone. We just can't enroll them over the phone like we do with the MedSup.
Okay. The next question I have is, what is the age limit on this product?
Oh, 45 to, is it 85, Rashawn?
Yep. Yep.
We were selling it below age 45, but we had some agents figure out they go out and sell it to ladies that were thinking about having a baby, or maybe they were a month or two pregnant and they were writing that, and once they got past the 6-month pre-ex, we had to pay benefits, so we had to change the age limit. It's always somebody out there trying to figure out how to scam the system, and they did, so we raised the age limit to 45.
Okay, you may want to clear this up again. We have a lot of them questioning, does the rate go up when they get older as they increase in age?
No. It's an issue age plan. They always pay the initial rate extra. And we've not had any rate increases on this plan, nor do we expect to have any. We think we have it priced actuarially to where it should not be going up in premium. And I've sold a lot of hospital indemnity plans in the last 30 years, and none of them have went up yet. Continental's had one out there that we used to write a lot of, 10, 12 years. Never had a rate increase.
Okay, that was actually the last question that I did have today.
Okay, great questions. I appreciate everybody joining us. Again, AEP is right around the corner. If you have any questions, need to get contracted, or need help with Medicare Advantage, we can have Chris Lee give you a call, walk you through those benefits, and show you how this plan fits hand in hand with that product. Please call us if we can help. Let us know, and we will help you any way we can. So again, thank you for joining us. Have a great day, and we will talk with you next time.